my name's Alex, and today I'll be taking you through the background and some early results from our study on the lived experience of CPAP and BiPAP treatments in myotonic dystrophy. I'll be referring to CPAP and BiPAP through this video as NIV, which stands for non-invasive ventilation. This is an umbrella term for the two. If you don't live with myotonic dystrophy, this video may still be of interest to you, as it describes a lot of the experiences common to muscular dystrophy. This research was carried out by the Prince Charles Hospital Sleep Disorders Centre. We were helped by Muscular Dystrophy Queensland in recruiting, and the project was co-designed with the consumer investigator Noni from the Community Liaison Group. Why did we do this research? Myotonic dystrophy is the most common adult onset muscular dystrophy, but there's been very little research done on it. Many people with a muscular dystrophy experience sleep and breathing disorders through their life that impact their quality of life, capacity, and long-term health outcomes. The main treatment for sleep-disordered breathing and muscular dystrophy is CPAP or BiPAP, depending on the type, but many people can struggle to use and benefit from these. It appears to be especially difficult in myotonic dystrophy, and we don't understand why. The lived experience of these treatments in myotonic dystrophy had never been described before, so we decided to ask users. We had 3 goals: to describe what CPAP and BiPAP treatment is like for people with myotonic dystrophy, to understand how experience of disease and healthcare affects this, and to uncover any unmet needs for future research. How did we do this research? This project had 5 steps. We started by designing and piloting questions with a consumer investigator. We then recruited through a community and had one-on-one interviews over the phone or Teams. Each line of each interview was recorded and entered into a sheet. We then analysed each line to understand the code and the concept being talked about, the phase of the experience and the emotion, whether that be negative, positive, or neutral. We then counted all our codes and organised them into themes and sub-themes. In this study, we had 20 participants, half of them women, and 17 living with myotonic dystrophy, 3 carers. Of the 17 affected individuals, 14 were current CPAP or BiPAP users, and 3 had previously used therapy but ceased. The majority of respondents were in Queensland, followed by West Australia, South Australia, and Victoria. We generated 7 phases and 7 themes of experience. The 7 phases were myotonic dystrophy diagnosis, living with myotonic dystrophy, sleep-disordered breathing diagnosis, NIV initiation and acclimatization, using and managing NIV, ceasing NIV, and my future. The 7 themes were life impact of myotonic dystrophy, confident self-management, quality of care, supported care, education and information, research participation, and the experience of NIV. The negativity and the positivity of themes change between phases of experience. In the graph showing total negative and positive theme counts, we can see the most negative theme was impact of myotonic dystrophy on life. Meanwhile, the most positive theme was confident self-management. Life impact of myotonic dystrophy described how people were affected by the condition. This theme was mostly negative and included sub-themes of healthcare burden, psychological impact, family impact, and quality of life impact. Experiences varied based on a number of factors, including age of onset. For some people diagnosed before onset, progression was most challenging. It's frustrating to learn to live without things I used to be able to do. Like getting out of this bed is difficult now because I just don't have the strength. For others who experienced symptoms first, diagnosis was a positive experience. It was validating. Everything that was happening wasn't just me being broken, there was something wrong. Many people use family members to understand how myotonic dystrophy would affect them, and worried for their future capacity with the disease. There are still so many things I want to do. I want to go overseas, I want to travel, and I can't do that if I'm bedbound. Confident self-management was the most positive theme and described the way people were managing in their day-to-day life with disease. Sub-themes were, I have ways of managing with myotonic dystrophy, motivated management, and confidence in understanding. A lot of people believe they had to be resilient. There are good days and bad days, and this concept of spoons and running out of spoons each day is quite true. It's a balancing act, and you just have to be flexible with it. Just roll with the punches. And wanting to live the best life possible despite the condition was a key motivator for many. What I want for my wife is just to keep her stimulated and getting her still doing the things she wants to do. Quality of care referred to the personal understanding of healthcare quality. High-quality healthcare was defined by being accessible, efficient, effective, timely, patient-centered, and safe. A lot of respondents had experienced both high and low-quality care. Accessibility and patient-centered care were key areas for improvement. People were concerned about geographical access to care and financial access to treatment. These machines are very expensive, I think $3,000 to $4,000. For a lot of people, that's out of reach. Many also wanted to have more of a say in their care. I never got asked what I want to do, how I feel. Supported care described the different circles of support that participants were accessing. Sources of support included friends and family, treating healthcare professionals, community allied health, and the myotonic dystrophy or muscular dystrophy community. Support from friends and family was the most positive, and relationships with healthcare professionals were very mixed, with good and bad encounters through the treatment journey. High-quality support from healthcare professionals was consistent, empathetic, holistic, coordinated, and proactive. Some examples are, my neurologist is very good, but she's frank, not very sympathetic. And before I found the doctor I'm seeing now, I did feel that I was teaching them more than they were teaching me. Education and information contain subthemes of effective education, education on what to expect, DM knowledge and understanding, burden of self-education. Over half the respondents felt like they hadn't received enough information and were forced to look for it themselves. It's hard to get advice, you really need to chase it up for yourself. For me that's okay, but for older people or for some people who are really sick, it can be harder to get that help, get that support for it. The lack of education was understood to be a consequence of low physician and societal awareness of disease. Not many people know about it. If I say muscular dystrophy, then they get an idea of what it is. Research participation was something many people felt motivated to do, but their ability to do so was limited by accessibility. Many people viewed research participation as something they should do to increase their own and researchers' understanding. I think it's good for me, for my own personal feeling of not being alone in this, but also wanting to put my experiences out there and my opinions out there, and for people researching this condition to have an understanding of what it's like for people who have the condition. But confidence in a cure or treatment for myotonic dystrophy was low. Though the Facebook group you can see if there's anything that's actually happening, and there doesn't appear to be any answers yet. Lots of research but no answers. It's just finding the time to plug in when you know there's not real answers. The experience of NIV described the factors that influenced acceptance or refusal of treatment. These were treatment burden, treatment effectiveness, and confident management. Where treatment negatively impacted quality of life or was difficult to manage independently, acceptance was lower. For example, so now we've got the Darth Vader thing going as well, and my husband said he could hear it sleeping next to me, and I'm the one wearing it. With using the chin strap, I can't put them on, so I can't do any of that. It's difficult now getting the mask on as it is, and that's just getting about impossible on my own. There was a common belief that the initial discomfort of treatment was worth the benefit, and you just need to persist. You will loathe it. You'll wish you could throw it out the window, but don't quit it. Keep with it and use it, and you'll wonder how you could survive without it. In this research, we made 4 key findings. Firstly, that experience is highly personalized. We know that people with myotonic dystrophy are incredibly variable, and their treatment experiences are variable as well. Secondly, that themes of experience are interlinked and influence one another. Surrounding themes of disease and healthcare impact influence the experience of NIV and ultimate acceptance. We saw that NIV acceptance is modified by those 3 key factors of effectiveness, burden, and ability to manage. We also saw that myotonic dystrophy users were reporting unmet needs for treatment effectiveness, care quality, care support, education and information, and research participation opportunities. This research is part of a larger study on sleep and breathing needs and priorities in muscular dystrophy. In the next phase of this project, which is currently underway, we will collect information on the community needs via survey. We will then get a group of health professionals together to brainstorm ideas to address those needs. You can participate in our survey by scanning the QR code with your phone or going to Muscular Dystrophy Australia's research page to find the online link. In the next slide, we'll share a Q&A with Noni, who helped us with this research.
I want to see the future better for people with the condition. So if somebody's doing research that's going to improve their condition in the future, then that's great. Because if I can give back a little bit for that, I'll feel that I've done something for the research, because there's not a lot known about myotonic. I mean, a lot of people know bits and pieces, but they don't really research it very well. Everybody knows that it's multifaceted and that sort of stuff, but yeah, when it comes down to specifics, people, doctors don't know anything. A lot of clients don't know anything, and that sort of stuff. So yeah, if we can find detailed information that will improve a person's life, that would be really good, I think. Everybody is different, and I think that's one of the hardest things, Alex, is the fact that my brother and I both, from the one parent, both had diagnosed with the same condition, but we presented differently, and he had, his lungs were more affected than me. He ended up on a BiPAP. I only had a CPAP. I'm no longer using the CPAP because, I'm not having the problems that I was having and that sort of stuff. But other people you talk to, they can't get their CO2 levels right and that sort of stuff. And you think, well, there must be a solution, to that. You must be able to solve that. But you've got to have somebody who understands what you're dealing with, where myotonic dystrophy is coming from, so that they can look into that particular thing. If people can be, we know about it, it's not a scary thing, that you can live a full life and all of that. I think that's got to be something good. And I think, meeting other people who have had lived experience of CPAP machines or BiPAP machines, and finding a solution to something that might be a problem for you, and knowing that it can be fixed, has got to be a benefit, doesn't it? With your particular research on the CPAPs and BiPAPs, everybody's got a problem, and you talk about, they start off on the CPAPs and all of a sudden they go, this isn't working, it doesn't work for me, I don't want to use it. And you think, well, have you tried a BiPAP? Oh, is there such a thing? How does that work? And there's another avenue. You don't just have to give up and be tired all the time and falling asleep all the time.
Hi everyone, I'm Alex. I'm one of the researchers on this project. On behalf of the rest of the team, I just really wanted to thank everyone who's been involved for their openness and their willingness to share their experiences with us. What I think we're hoping to get out of this research is, first of all, to represent your experiences of sleep and breathing treatment and also of myotonic dystrophy. And I think a big part of this research has been understanding that myotonic dystrophy, it's a lifelong condition, and it's going to be affecting, your home life, your experience of healthcare, and your experience of therapy. So when we're starting something like NIV treatment, it needs to be considered, and we need to be treating everyone individually. The second thing that I'm hoping to get out of this is just to help healthcare professionals understand what living with myotonic dystrophy is actually like and what that entails, and supporting that personalised treatment. Something that was really interesting for me in this project as well, and really heartbreaking, was the feeling that a lot of people had of isolation and being alone in the experience of rare disease. When we were putting these results together and reading through everyone's stories, I was amazed by how many overlapping and shared experiences, beliefs, and needs that people had. So what I'm hoping is that in hearing about these results today, or reading about these results when the published paper comes out, people with myotonic dystrophy can feel that they are seen, they are heard, and that there is a place where their experiences are showcased. And in that, they're not alone. Thank you all. If you would like to get in contact with us to ask a question or leave feedback, you can do so using the information on the screen. Thank you for listening.